Hi, everyone. So it's 1 o'clock. It looks like we've got a lot of people joining. So we'll get started, and this will be recorded, and we will also post that in the slides later on. But so welcome to our APIC Great Lake spring webinar for May. We're glad you all could join us. Today we have Amy Williams from STERIS, and I'm going to give just a brief introduction for Amy. So Dr. Amy Williams is the Senior Manager for Clinical Education for STERIS Instrument Management Services. She holds a Bachelor of Science in Nursing, a Master of Science in Nursing Education, and a Doctor of Nursing Practice in Organizational Systems and Leadership. And then Amy has over 30 years of experience as a registered nurse, and 26 of those have been in the role of a nurse educator. So she has extensive experience in perioperative setting with onboarding, competency development, regulatory compliance, process improvement, and quality management initiatives. And she holds multiple certifications in nursing and central sterile processing. She's a published author, and she serves as a peer reviewer for nursing journals and textbook publishers. And Amy is dedicated to advancing quality improvement education and evidence-based strategies that foster excellence in healthcare and nursing and promote positive patient outcomes. So we're super excited and happy to have Amy today. Just a quick introduction. And then before she starts, I just wanted to go over a quick couple of slides. Um, so just a reminder, we've got our fall APIC Great Lake Conference in October. That's the 15th. It's a Thursday. So please sign up for that. And we have our theme here is going to be a bridge over troubled waters. So keep that date on your calendar, keep it free. And then also, if you're interested in attending APIC National in June, please go to this link and complete the Google form so that we can have your contact information. And then just another reminder that any jobs will be posted here. So if you have one, they'll be on our LinkedIn page, and you can just send us an email for the job opening, and we can get it posted. And then, like you said, this will be posted to our YouTube channel, so you can go back and watch it later. And the link is right here. So without further ado, Amy, welcome.
Awesome. Thank you so much. All right, let's see if I can. We have to stop sharing, Julie. There we go. Um, I'm not seeing the share option.
Julie, you may have to take your slides down and stop sharing so that Amy can do it.
Yeah. Could you try again now, Amy?
Here we go. Perfect. Okay. Awesome. Well, thank you very much. Can you guys hear me okay? I'm assuming. If not, somebody let me know.
We can hear you, and your slides look great.
Okay, great. Well, thank you so much for having me, guys. I'm very excited to be here and to be able to go through all of this with you. Just housekeeping up front, just so you know, this is not new information. Actually, these updates to this standard came out several years back. So what I'm giving you today is more of a breakdown. I don't know, a lot of people aren't even familiar with this standard, so I like to go through it. But just from the get-go, I'll let you know that it's actually not new. These changes came out quite a while ago. So she already talked all about me. I don't want to do that anymore. I do want to let you guys know that I do work for STERIS. Y'all know that, but I don't have any other relevant disclosures to mention today. I'm just super happy to be here to give you some good education. Everything I'm going to talk about today is evidence-based. Okay, so it's not my opinion. It is not something that, we think is the right way to do it. It literally comes directly from the guideline itself. And what we're doing here is kind of talking about what used to be and then what's changed. So that's the point, is to highlight the differences. And so that comes from the old guideline and the new one. And then a lot of this also I pulled from different presentations, different conferences that I had attended back in 2022 when this information first came out. So just know that everything's evidence-based. And I believe you guys have copies of the handouts. So if you have questions about anything, you can certainly reach out and let me know. But you'll have that information to refer to. So like I mentioned, we're going to talk about the changes between the 2015 guideline and then the updated version that came out at the end of 2021. We will talk a lot about high risk endoscopes, what those requirements are, how that's defined, what do you do with them, and from an infection prevention perspective, what do you need to be looking for in your endo departments? Okay. We're going to talk a lot about quality management today, and that includes cleaning verification, drying verification, microbial surveillance specific to endoscopes, what those expectations are from a guidelines perspective. And then again, as infection preventionist, if you're working in an endoscopic department or overseeing those areas, what you kind of need to be aware of and be looking for. That also feeds into quality assurance, what that process should look like in terms of reprocessing endoscopes, and then just how to take some of these concepts and apply them in your departments. So the goal is always to follow best practice, to develop good policy, robust policy and procedure. And we want those policies and procedures to be based on best practices. So again, just giving you that information today. So historically, sorry guys, here I go with my technology finger. Sorry about that. Historically, this guideline has a version of it has been in place for a while. So the previous version was dated 2015. This one came out it was officially adopted in 2021. It actually wasn't published, made available to the public until March of 2022. So we are over 4 years in now. Most people I find don't fully understand ANSI AAMI and the guidelines and what all that means. So the organization, ANSI AAMI, basically gives us best practice around medical devices. So all kinds of medical devices, and this guideline in particular, ST91, is specific to flexible and semi-rigid endoscopes. And I want to emphasize that because it's not just flexible devices, it's semi-rigids too. So we get into our cystoscopes, ureteroscopes, and things like that. This new guideline dated 2021 replaces 2015. This is not an addendum. So that doesn't mean that part of 2015 still applies. This document completely replaces the old one. Another thing I do like to point out, because I find that most people aren't aware of this, and infection preventionists, I have always found tend to be very like, where's the proof, right? How do I use this and where's the proof? And I love that because I think that's super important. So all of these AAMI documents, not just this one in particular, have different sections. So there, in this guideline, there are two parts. There's a normative section, which is the evaluated, evidence-based material. It is the approved standard. It's the part of the document that was debated, voted on, and accepted because it had a lot of peer-reviewed evidence to it, and it's considered best practice. So it's the best practice portion. It's the normative section. This is the part that is going to be used in the survey process. It's what your departments are going to be measured by. Okay. So that's where the compliance piece comes in. And then toward the end of the document, There are informative appendices, and you're going to see these referenced as I move through the presentation. Each slide kind of tells you, what section of the document that the information comes from. And if there's a correlating appendix, it'll be listed too. And I'll point that out in a minute. But the informative areas or these appendices are just that. They're informative. They're meant to give you extra guidance and extra information about how to interpret the other parts of the document. So when we get into this, especially if you're new, maybe not a new infection preventionist, but you're newer to endo, you may not understand exactly what they're talking about, or even for me, it was difficult to, well, how do I apply that? How do I make that work? These informative appendices are meant to give you guidance on that. So please, if you're not familiar with them, I would highly recommend that you look at them. Okay. And if you don't have a copy of this standard, if you're in an endo department, you don't have a copy of this, I highly recommend that you purchase one. It's not free. It is for purchase through AAMI, not me, the organization, but it's very, very good, very, very helpful. Okay. So overall in this document, the biggest changes are that there's a lot more evidence-based data. So they've done the research. They've really looked for the statistics, and they can really robustly say, we want this to be best practice, or we've decided this is best practice because there's a lot of data that supports that action. And that's good, right? Where's the proof? Well, they give it to you. So peer-reviewed data, peer-reviewed research is very strong. And then there are some newer sections, and we'll touch on those as we get there. Just some things that we've kind of always done, but it's never been formally documented or formally included in the standard. And now it is. So again, I'll hit on that. Excuse me while I have a cough drop. Hope y'all haven't had all of the mess that's been going around, but it's been rough down here. All right. Another thing that is super important, I feel like, for you to be able to navigate these documents is to understand terminology. So the terms that you see here are keywords that are used throughout the document, and they help you interpret and understand what you should be doing. Now, these are not specific to ST91. They are in all AAMI guidelines. So, this little review situation here will help you for all of them. All right. So first and foremost, anywhere in the guideline that says you must do something, and it uses that verb, must, because I always like to say verbs matter. They do. A must is an unavoidable action. It's a requirement. Okay. And this is a requirement from a federal level or another governmental mandate. So this actually kind of supersedes AAMI. So the musts pertain to OSHA, FDA, DOT, CDC, governmental entities. So if it says you must be doing something or you must not do something, that is an expectation of compliance. Okay. It's an external constraint or external obligation that's defined outside of AAMI. So those are the big ones. There aren't many of them, but the ones that are there are very important. Now, the rest of the verbs on the page are AAMI terms. You might see them overlapped in other documents, but these definitions apply just inside of the AAMI organization. So shall not. AAMI considers anything that's a shall to be a requirement. That's something that has a lot of good peer-reviewed data to support it. It has strong consensus. It's considered to be best practice, and AAMI says it should be followed. Should or should not. Very strong recommendation. Not a requirement, but it also has a lot of peer-reviewed data. It has a strong consensus. It is considered to be maybe not the best practice, but it is considered to be good practice. It's the action that AAMI really wants the department to use. Again, not required, but if you've got multiple options, the should or the should not is the one they want you to choose. May, can, and might are all statements of possibility. And in my days of as being an educator, I say a lot. Just because you can does not mean you should. And I use that to help people think about their choices. There are lots of different options. When we talk about reprocessing endoscopes, there are many different ways to do that. There are a lot of different options. The may, the can, and the might are meant to guide so that you consider what those options are in light of what is best practice, what are the facility capabilities, what is my budget. You consider the may, can, and the might, and then you pick what's safest. You move toward what's most feasible for your facility. Okay. So an action might be permissible. It might be something that a person can do or a facility can choose, but might not be the best choice. Now, I always do say, just because you can smoke crack doesn't mean you should. And that usually gets a good chuckle and everybody likes it because it's funny, but that's the point. A lot of times staff will tell us, well, that's the way we've always done it. That's how I was trained. But that doesn't necessarily mean that that action is the right one, is the safe one. In fact, it might be something that is very detrimental. So, AAMI leaves interpretation around these verbs because there may not be a lot of data to support them, or, consensus to support the action. So there's leeway there. And AAMI understands that these standards are not universally applicable. It's not a one size fits all for every hospital. Budgets are different, capital purchases are different. So compliance may not be immediately achievable. So they do take all that into consideration. Okay. And they'll tell you in the very beginning of the guideline, it says that they should be used to guide staff performance. They should be considered and applied with professional experience and judgment, and that you should review your practices and the standards on a regular basis and then adapt to the needs because things change. That's what happens in our world, especially in the perioperative setting, which endo many times kind of crosses over to. New doctors, new procedures, new types of bugs, all kinds of things that come out. So that we should be constantly doing an ongoing quality process to make sure that we're getting quality outcomes. Okay. And that's kind of where you guys come in, I feel like. Sometimes infection prevention can get things done when a department manager can't or doesn't know they should. So being aware, reviewing the standards on a regular basis, and then helping the departments adapt to them is crucial to patient safety. I mean, I can't say that enough. All right, so let's jump in here. We're going to start talking about the changes. And this is what I was talking about at the beginning. Let me turn my little pointer here. So right up here at the top, it tells you the section that this information comes from, section 6.6.2. If there's an annex that goes along with the information, it will also be listed right up here at the top. Okay. All right. Turn that off. So as far as PPE goes, nothing new here. There's no change. It's just the way the standard is written now, the PPE language is woven throughout every section, and there is a ton of emphasis now on wearing the correct PPE during reprocessing, what kinds of PPE is being worn when you're handling clean versus dirty devices, and then changing your PPE between each step of the reprocessing cycle. So I'm sure that you guys know that as nurses, we don't always like to change gloves. We don't always think about washing our hands, especially if we don't necessarily think that it was necessary in the moment. And we see that a lot with scopes as well, especially when you're working in decon. People just have a mindset, oh, this is a dirty area, and they don't necessarily change PPE the way they should. So the emphasis to this section is just making sure that folks are doing hand hygiene, they're wearing gloves, they're wearing the appropriate PPE when they're washing a dirty device, handling a dirty device, and then changing gloves as it moves from, manual cleaning, post manual cleaning, we're getting ready to put it into an AER. And then after the AER is completed, that folks are being mindful of that. They're doing hand hygiene and they're changing PPE as necessary. Okay. A lot of emphasis too around clean PPE before we're doing cleaning verification and doing inspection of that scope. So again, just being aware. And early on, I did hear a lot of folks talk about in surveys, they were being very closely watched in terms of, how they were doing their PPE. I don't know. I haven't really heard anybody say anything lately, but I think that is something that people, surveyors are always looking at. So it's definitely something to make sure staff is aware of. All right. Certification, training, competency validations. So education. Well, first off, this might be a little bit outside of an IP realm. This would be more of an education issue, but the guideline does say that all staff should have certification, training, and competency validations done at certain times. And just so you know, certification, uh, education, training, and competency validations are three different things. Okay. Education is where we give information. Training is where we teach somebody how to use that information. Competency validation is where we determine that an individual that they have learned it, they can do that work, and they are competent at it or safe doing it. So three different entities, three different things. The certification question always comes up. Do all of my employees have to be certified in endoscopy, reprocessing or sterile processing or anything like that? So this particular guideline, they say that your employees should be certified within 2 years of employment with your facility. So there is no national standard or blanket statement that says everybody has to be certified. They do give you a 2-year window, and it is specific to your hospital or your system. So what that means is if you've got employees that are working for you and they've been there 1 year, 11 months, and 2 weeks, and then they leave and they go to work someplace else, that clock starts over. That 2 years just resets and starts over because it's tied to the employment at the facility. As far as education, training, and competencies, obviously those are to be done before a new employee comes off orientation. We want to make sure that they are, well trained and can work independently. And then minimally, they should be done annually. As a facility, if you've got more intricate devices or harder to clean devices or something new that people don't use a lot of, you can opt to do education, training, and competencies more often. You might do them quarterly or every 6 months as opposed to once a year if you as a facility deem that's necessary. But at minimum, education, training, and competency validation annually. Now, that's our checkoffs, right? That's having somebody come in and observe and, an educator's observing all of the staff. It is also recommended that you work into your policy around this whenever there are new scopes, new devices, new processes, new doctors, new products, anything new that comes into the department. There definitely should be some education and training on it. And then you determine if competency checkoff is necessary and then how often you want to do that. Okay. And then obviously you got to have all that documented. So you want to keep good education records that can be produced in a survey if requested. Also, let me go back and point something out here. Education, training, and competencies should be completed by staff for all devices and or processes. We don't just educate the few people that are only doing certain things. The guideline says all staff, all devices in your inventory. Okay. So a lot of times I'll hear people say, oh, well, that person doesn't ever use that, or they don't ever reprocess that, so they don't have to have competency on that. And the guideline speaks differently. Okay. So just want to point that out. All right. Departmental design. This is section 4 of the guideline, and it is fairly extensive. The main changes from the old 2015 to now, it just really kind of reinforces how the layout should be. Now, I'm going to say up front, I want a disclaimer here that I do realize that endo wasn't a thing 50 years ago, 60 years ago. Endoscopy is relatively new. So a lot of our hospitals that have been around a really long time didn't have an endoscopy department. It wasn't even thought about. So when it came time to do a lot of endoscopy, administration just really, it's like, where can we put them? And so departmental design really wasn't even a consideration. It was, where are we going to stick endo and where can we do that work? So a lot of times our endoscopy departments are really working at a disadvantage because they're just limited in the space that they have. I like to make a joke sometimes that, it's the smallest closet that nobody was using. And they said, oh, well, we'll just put them here. Because sometimes that's what it feels like. But very clearly, there are some requirements for your physical layout. One, there has to be a strict unidirectional flow from dirty to clean. Now, I know that makes sense, right? Dirty to clean, no backtracking. The hard part about that is in endo is that a lot of times once you get into, you go from decon into the clean work area, there's no way to get out of the clean area without going back through decon. And people don't think a lot about that because they just don't see scopes as, they're not necessarily always sterile. So they don't think it's that big of a deal, but it is. So if you've cleaned that device, you've taken it out in AER, you've dried it, whatever, you shouldn't be going back through decon. So if that's an issue for the layout of your area, that's something that definitely it warrants conversation with admin about how we can do it differently. We need more space. Ideally, there should be a 2-room design. You want 1 room for decon. You want to separate that manual cleaning area from places where we're doing clean inspection, disinfection, and sterilization. Okay, so ideally 2 rooms, completely separate. If you don't have 2 rooms, you can use a 1-room design, but there should be a minimum of 4 feet between decon and where the clean work area is. So definitely a designation in those 2 spaces with a minimum of 4 feet. 4 feet is always because of the droplet, the splash factor. However, I will tell you that there is some new research that's been recently published. I want to say over the last year and a half or so, where it was a splash study and it documented splash in a 1-room setting up to like 15 feet, 20 feet, something like that. So you do have to consider the volume that's being done in 1 room and what is the potential for splash? What's the potential for contamination if you're working in a 1-room setup? Okay. Ideally, in your departmental design, again, ideal is 3 sinks. So 1 for leak testing, 1 for manual cleaning, and then a 3rd for nothing but rinsing, just dedicated for rinsing. Again, older places don't always have 3 sinks. Some people don't even have 2 sinks. So in that case, Minimum, the guideline says a minimum of 2. So you can do leak testing and manual cleaning in one, and then have a dedicated sink for rinsing only. If you only have a one sink in the department, you can use that sink in a basin or that sink in 2 basins. Whatever works for the area. But you do have to have more than one sink. The sink has to be large enough to accommodate a long scope and a loose coil. You have to be able, it has to be deep enough to be fully submerged. The guideline does have some size dimensions in it. Your hand wash sink doesn't cut it. You know, the eye wash sink, you can't use an eye wash sink to reprocess a scope. A hand wash sink is not meant to be used to reprocess. So again, if these are issues because the department was sort of an afterthought, then that's a conversation that needs to be had with admin, because those are the types of things that will get you cited. Pretty straightforward in that regard. We're going to talk more about drying and storage later, but you do have to have designated areas for drying your scopes in designated separate storage areas once they're cleaned and reprocessed. All right. High-risk devices are not new. They have always been around. AAMI just really has solidified a definition and given us some guidance around that. So this is in section 3 of the guideline. AAMI says that these scopes are, a high-risk scope is one that's deemed especially difficult to clean. And as such, it poses a greater risk of cross-contamination and the potential to spread infection. There are really kind of 2 angles that they come at that from. One, it's a scope or a group of scopes that have been associated with an infectious outbreak in the past. So that's our duodenoscopes. And then the other angle is they're complex. And the more complex a device is, the more difficult it is to reprocess. So those that are very difficult to process because of their physical design are classified as high risk. Now, there are 6 categories. You see them listed here on the screen. These are always and forevermore considered high risk by AAMI. And AORN aligns to this too. You can never say at my facility, cystoscopes aren't high risk. They are always, according to the AAMI guideline. So just keep that in mind. You can add other groups of devices that aren't one of these 6 categories. You could put another category on here if you wanted to, if you did a risk assessment and felt that it was pertinent. You could add to this list, but you cannot take any away from the list. All right. And this is the part too that kind of overlaps with what I mentioned earlier. Endo is usually just endo, but our semi-rigids fall into this high-risk category. And a lot of times sterile processing isn't really aware of that. So this might be an overlap, depending on how big the facility is. If it's one infection preventionist, it's kind of doing it all, or if you've got different infection preventionists for different areas, this might be an overlap conversation. Okay. Mostly, we're looking at these because of the way they're used, which I will revisit later, but it's not just the category of device, it's how that device is being used that kind of factors into this as well. All right, point of use. In terms of point of use treatment, that's the new term. We used to call it pre-cleaning or bedside cleaning. People still call it what they call it, but officially it's now point of use treatment. And the emphasis here is that that process should happen immediately after patient use, regardless of the location of use. Notice I didn't say at the end of the case, at the end of the procedure. We're trying to shift emphasis to as soon as it's used, we don't want it to sit dirty for a prolonged period of time. Okay. So immediately after patient use, no matter the location. Maybe it's in the endo department, maybe it's in the ER, maybe it's in the ICU. Um, doesn't matter. The rules are the same across the board. If that scope is being reused in a procedure, obviously it should be flushed and wiped on the outside between those uses. And if it's sitting for a prolonged period of time in that same procedure, then the recommendation is for you to consider just exactly how long is it sitting, and do we need to send that one off and get a new scope for subsequent uses? Because we all know biofilms can start to grow really, really quickly. And I've been asked this question a lot actually about, oh, we've got situations where, let's say they bronch a patient in the beginning of the procedure, then they do some sort of minimally invasive surgery, and then they want to bronch again at the end. Can they use the same device for the bronch? And my answer to that is always, how long is it between those two bronchs? If it's more than about 30 minutes, you got to think about biofilm and what's the science around biofilm formation. And then as a facility, risk assessment and determine, is this going to be best for us to reuse this device, or do we need to get a new one? So again, food for thought there, right? What's going to be safest for the patient? Also, there's a new requirement for a written handoff process. So when that scope is done, you're done with it, you're ready to send it to decon, or you're not going to use it anymore, there should be some sort of identifier, a tag, a label, something that indicates what time the point of use treatment was performed. Whoever's doing manual cleaning needs to know how long that scope's been sitting. Ideally, how long has it been sitting after point of use? Because that determines what kind of reprocessing flow we followed. I'll talk about that in a minute. But if you don't have some mechanism in place at your facility, just know that that is part of the guideline now, that you have a handoff to where you can tell whoever was at bedside can tell whoever's doing manual cleaning, this is what time I did point of use. This is how long it's been. Okay. Very important. Transport, nothing new, just a lot of expanded language that just really emphasizes we're protecting the device, but we're also protecting the environment as we're moving a dirty device through it. So, the right kind of transport. We want to keep the scope moist. Again, we don't want things to dry. Anytime bioburden dries inside that device, it makes it harder to clean. So keep it moist, but not submerged. Pre-treatment, enzymatic, even just, water moistened, sterile water moistened towels. We don't ever want to soak a scope in saline. We don't want to really expose devices to saline. It's not good for them. So if they are exposed to saline, the recommendation is to wipe them off with sterile water immediately after. But definitely don't want them to sit in a moist environment or in a submerged environment for a prolonged time. Okay. Your transport product, whether it's a bag or a container, regardless of what it is, it should be an approved transport container that's leak proof, non-porous, puncture resistant. You should have a biohazard label on your dirty devices, and use that handoff process. Ideally, you should not hand carry anything that's dirty. The recommendation is to use an approved transport container of some sort. Even if the distance is very short, people tell me, well, I'm just going across the hall. I'm just going right down the hall. It's not far. Well, the recommendation is to always use a container. Okay. So evaluate that. That might be something that needs a risk assessment. Just exactly how far are we going? What's the possibility of getting sidetracked while I'm holding a dirty scope? Delayed reprocessing. This is kind of that time factor where the handoff process, right? So how long do we have to get manual cleaning started before we have to take special steps or extra measures. The golden hour, 60 minutes. That's kind of universally understood. According to AAMI, in terms of best practice, manual cleaning should begin no more than 60 minutes after point of use has occurred. The IFUs for your devices should also specify what is an acceptable time frame. And sometimes we get into, well, what do I follow? Am I following AAMI? Am I following the IFU? What do I do? And this is where the critical thinking and the risk assessment has to come in. AAMI says, and AORN says this too, manual cleaning should begin no more than 60 minutes from when point of use occurred. We don't want scope to sit dirty more than an hour. Even if point of use was done and done well, we still don't want that scope to sit more than an hour. Sometimes the IFUs will say begin manual cleaning within 90 minutes. In some cases, I've seen them say 120 minutes. So you have to think about the principles of biofilm growth, what's safest. So that's a facility decision. You write that into your policy. So you do need to refer to the IFU and then consider all of the infection control principles around biofilm. Okay. That delayed reprocessing it should be specified in the IFU. It should tell you exactly what steps need to occur if you are going to do a delayed reprocessing cycle. And those should be followed. It might be a longer soak. It might be extra brushing, just whatever the IFU specifies. But it should be followed if manual cleaning can't begin within that 1 hour time frame. Okay. If the IFU does not specify a time, like a maximum amount of time, then, I would recommend that you defer to AAMI and AORN, the best practice documents and consider what would be safest for the patient. Okay. Lots of different circumstances where delayed reprocessing might be necessary. What I mentioned a minute ago about, they reuse the same device within a procedure and maybe it just sat for a long period of time. Maybe point of use wasn't done or it wasn't done very well. So you might want to do a delayed reprocess in that case. Heavily soiled cases, a lot of times we have folks that don't do their preps well. And so we've got a colonoscope that's heavily soiled. Maybe we've got a really bloody procedure, a lot of tissue or something. So you can always do a delayed reprocess in those cases. Remember, you can always err toward what's safer or more cautious anytime you want to. So, and here's an example of what I talked about. You see section 7 is where this information came from in the guideline, but the Annex F is specific to delayed reprocessing. So it's got a lot of that informative material in it that you could use to help, develop your policies. All right, leak testing. Big takeaway here. First off, do it. You should be doing leak testing. There's never an option really for that. A lot of facilities, oh, we don't leak test XYZ. Well, you should be. Secondly, if you cannot successfully leak test a device, don't use it. Take it out of service. You should never use an endoscope that cannot be leak tested. So if you're having repeated failures, that device should be tagged and it should be removed from service and sent out for evaluation and or repair. Okay. And that's very clearly stated in this section. What that tells me is there are a lot of people out there who continue to use devices that can't be leak tested or don't leak test at all. So AAMI was very clear with their language here. Okay. They also added a requirement that you should regularly calibrate your leak testers. You should test your testers every day that they're used. So no matter what, if you're doing automated or manual, as it should, that it's properly functioning and that it gives you good, valid pressure outputs. Because if the leak tester is broken, your leak test is worthless. Okay. So you should be testing your testers every day that they're used. and documenting the outcome of the leak test. So clipboard, tracking system, 3-ring binder, whatever works for your facility, but your staff should be checking those testers and saying, yes, valid, works, pressure output, whatever you decide, however you want that to look. But you should have a record of that and you should be able to produce it if requested in a survey. All right. Wet leak testing. Observation time has been increased to 60 seconds. It used to be 30. We now know that for a wet leak test, 30 seconds is not enough. So they bumped up the time frame and now it's a full minute. So part of your quality process is making sure that people are actually observing for a minute, okay? And all of that obviously should be written in policy, and that your staff are trained on that and that they know what to do when there is a leak. What do you do with that device? Part of your policy should specify how many times are we going to leak test the device before we take it out. We're going to do it once and pull it if it fails. Are we going to do it once, repeat it if it fails, and then pull it? All of that should be specified. Enhanced inspection, not new. This is lighted magnification, well-lit area with magnification strong enough to be able to see minute damages at the distal tip. Part of this enhanced inspection process is internal visualization of the channels. That's done with a borescope, typically, some sort of internal camera. Again, this is part of the enhanced inspection process, and AAMI says you should be using it, okay? And this is where I usually point out the verb, because it says internal channels can be inspected with a borescope. When this guideline came out in 2021, we did not have a lot of data around the use of a borescope. So they made it a can and not a should. It's not a requirement because not everybody has a borescope, but it's a good idea, right? Like you can't see down inside those channels with a naked eye. So the only way to know if they're clean, well, are they dry, are they damaged, is to look at it with a borescope. So they're saying, think about it. We see borescopes used a lot in decon after manual cleaning, just as part of cleaning verification, or on the clean side. I see them used in both places, just, quality inspections. Okay. It's really up to you to determine where to use a borescope and if you use one. Manual cleaning. Kind of already talked about all of this. Just make sure that we're getting that scope down there in a timely manner, that manual cleaning is started within that 1 hour time frame, just so that we can keep biofilms at bay. Cleaning is important, right? Like cleaning starts at the point of use and then follow through, and decon is essential. Making sure too, they talk about in this section about the delayed protocol and that you are familiar with what that is, because it could be different for different devices. So making sure that you are following the IFUs and that you're doing delayed cleaning correctly. Okay. PPE changes here also, from manual cleaning to when we're putting it in an AER, taking it out of an AER. Just as a point of note, air purges that are used as part of manual cleaning do not constitute drying. So we're going to talk about drying in a minute, but the air purge is just an air purge, okay? And then also automated reprocessing. So an AER. AAMI says that's meant to be used in addition to the manual cleaning process, not instead of. So there are some specific AERs or OERs that are on the market, and they are marketed that you cannot manually clean. You can skip that part and just put them in straight into the automated machine and it will do the cleaning for you. And AAMI says, pay attention to that because number one, those types of machines are very specific and they have to have a specific FDA approval. So make sure you know what your machines are. And then secondly, check the device IFU, because if it says it needs to be manually cleaned or it has to be brushed a certain way or whatever, that should be done in addition to an AER. Okay. Automated is always a supplement. Cleaning verification. So visual inspection inside and out, making sure that it is in fact clean. And then cleaning verification testing is whatever type of chemical test you want to use to ensure that residual contaminants have been removed. Lots of different things out there, protein, carb, hemoglobin, ATP, they don't specify. It's up to you to decide what needs to be used, what you want to use for your facility. Whatever you decide should be in your policy, and your staff should be trained on it. And it should be used consistently. High-risk endoscopes, the guidelines says they shall be monitored with cleaning verification after each cleaning, after each use. So the 6 categories I mentioned in the beginning: cystoscopes, duodenoscopes, ureteroscopes, bronchoscopes, EUS and EBUS. They should have cleaning verification testing performed every time they are reprocessed. So if you're doing protein, carb, ATP, whatever, that should be performed on those categories every time they're cleaned. Non-high-risk devices also should have cleaning verification testing performed at a statistically significant interval. So a percentage of those devices, non-high-risk devices, should be tested with cleaning verification testing at an established interval that is statistically significant. Maybe monthly, maybe quarterly. Again, it depends on your volume. It depends on your facility's individual needs. Okay. But they should be done. And a lot of folks don't realize that. And I also point out here too that if you're using one of the OERs that I mentioned a minute ago, where you bypass manual cleaning and you go straight into the reprocessor, my question for you is always, when are you doing cleaning verification testing? ATP, carb, hemoglobin, whatever those tests are, that's meant to be done after manual cleaning to validate that manual cleaning was effective. If you're not doing manual cleaning and you're putting it straight into the OER, when are you doing your cleaning verification testing? Okay. Because if you do it after it comes out of the AER, that's a moot point. Okay. So just think about that. Repeated cleaning failures, cleaning verification failures indicate the scope is probably damaged. So if you're failing your ATP or your protein test, if that device is failing, it's probably broken. So pull it out of service. That should be in your policy as well. Sterilization. It's always based on Spalding. We talk about critical devices that are coming in contact with sterile tissue, sterile body cavity, or vascular space. That requires sterilization. That's the same. Nothing's different there. So critical devices always need to be sterilized because there's very high risk of infection with those. Semi-critical devices, intermediate risk means mucous membranes, non-intact skin. The requirement for a semi-critical device is at minimum HLD. The question comes into play is, how is that device being used? Because some of what we classify as semi-critical devices are being used with sterile tissue, sterile body cavity, or blood, vascular. If that's the case, it doesn't matter that we label it semi-critical. The use is a critical way, and it should be sterilized. So I really emphasize here, make sure you know how these devices are being used, what kinds of procedures they're being used in. And this is especially true for EBUS and EUS devices. If they're being used for biopsies, minimally invasive pulmonary procedures, or minimally invasive GI um, surgeries for cancers. You got to think about how are they being used because it could be they need to be sterilized. Okay. Risk assessment is essential here. Look at your processes, look at your procedures, your doctors, what are they doing? How are they using them? And what needs to be happening? There's now a
And
recommend. Yes.
sorry, I just wanted to flag we have about 5 minutes left.
Oh, I thought we had an hour and a half. Okay, my bad.
That's okay.
Um,
Thank you.
all right. Recommendation now against manual disinfection and manual sterilization. Automation's better because we're human and we all do it different. So if you can put it in an automated reprocessor for HLD sterilization, that's the best. If a scope sits in an AER more than an hour after the cycle finishes, it needs to be rerun. It sits wet, that's a biofilm risk. Okay. Drying. So I want to hit this real quick. This is important. This is the big one. Drying should be performed for every device, period. Before it goes back for patient use or before it goes into storage, either one. You can manually dry or you can use a drying cabinet. But the goal is blow air, pressure regulated, HEPA filtered air blown through the channels for a minimum of 10 minutes, possibly longer, depending on the size of the device. It is up to you to determine, is 10 minutes enough? If not, you add more time. Okay. Air purge cycle in that AER does not constitute active drying. It is also up to you to validate that it's dry. So that's where the borescope comes into play. Alcohol really doesn't dry. That's a whole nother conversation we could do later, but alcohol just usually contributes to retained moisture. So you may not even need to do alcohol anymore. Storage, everything should be labeled as clean and patient ready. It should be tagged. We never store scopes wet, ever. And always use clean PPE when you're handling clean devices. So going into the cabinet to get a scope, there should be clean PPE. Storage should be done in a way to protect the device. Keep the doors closed, keep it clean. If the cabinet's dirty, obviously it needs to be cleaned immediately. Otherwise, those cabinets should be on a regular schedule to be cleaned at least weekly. Quality management. This is really around microbial surveillance, which right now is not a requirement, but it is strongly recommended that you do some sort of culturing on a percentage of your devices periodically, just to ensure that your cleaning processes are effective. Preventive maintenance, you should have a policy for this. It's not new. We've always done preventive maintenance, but you actually should have a preventive maintenance policy that outlines what is done with devices when a damage is identified. You need a chain of custody, so to speak, from the time that damage is identified to when it's sent out and then brought back in. And then what information do you get back from the repair? When you're sending devices out for repair, this is the must. This is the DOT federal part that I mentioned in the very beginning. You cannot put a biohazard out in the mail or on a truck on the highway without it being properly packaged and labeled. So DOT supersedes AAMI guidelines, DOT supersedes IFUs. So look at the IFU for how it should be packaged, like, for transport. If it's, dirty and if you can't clean it, you should clean it fully if you can. And if you can't, then you have to package it and ship it as a biohazard according to DOT regulations. Okay, done. I have 1 minute for questions.
Sorry
Sorry.
to rush you through the last few slides there, Amy. I do see
Sorry.
one in chat. Can we run it up for an extra half hour anyway?
Run.
And I don't know if Luke is still on to clarify or expand on that question.
Yeah, I don't know. I'd need a little more information about that.
Luke, I see you came off mute. Are you able to expand on that at all? All right, not hearing anything. Amy,
Yeah, can you hear me
oh,
now?
I can hear you. Yes, thanks. Go ahead.
Yeah, sorry, I typed it up in a playful way, but I was saying, can we still use that extra half hour? I was really hoping to get more into the nitty gritty on drying. And this is just great informative content. I appreciate it.
Well, I am happy to stay on. You know, I know that you guys are working and some people have to go. That's totally understandable, but I'm happy to stay on and talk through.
I've got about 15 minutes until I need to take off just as the host because I have to run to another meeting. But I'm happy, Luke, if you want to sort of ask additional questions and run into that. And Amy, if you have a little bit of time, that would be great. But I do recognize that this meeting was only scheduled for an hour. So for those of you that do have to run to other meetings, certainly feel free to do that. Otherwise, if you want to hang out and chat a little bit more, you're welcome to stay too. So with that, Luke, I guess I'll kick it back to you if you have additional questions or specific things that you wanted to ask.
My biggest question is what's the strongest case or wording that we can use when recommending specifically drawing the internal channels of the endoscope? Do you have any specific wording? I know it says should in AAMI, but do you have any additional thoughts there?
Well, typically what I say to folks is, I mean, you kind of have to link like point one to point two to point three, right? It's not just a simple yes or no cut and dried answer. So the longer a scope is wet, the more likely it's going to grow. Okay. So yes, the guideline says fully dried inside and out before use on a patient or put into storage. And then you bring in all of the latest and greatest data that says you can hang a scope vertically and it will never drip dry, right? It can be vertical for a month and there might still be retained moisture inside of it. Well, if that scope's not fully clean, then you're going to have a biofilm issue. So it's a difficult conversation, but those are the kinds of things that I talk about. Drying is not optional. Amy says you should do it. So does AORN. I don't know if that helps too much or not. It's extra time, right? Nobody wants to do it because they think it takes, and it does take extra time. I'm not saying it doesn't, but 10 extra minutes, 12 extra minutes in light of saving somebody from an infection, you know, that's the way I typically frame it up as well.
Thanks, Amy. And I do see another question in chat. The person indicates that they work at a new facility that isn't open yet, and there is a question on where we can put the drying cabinet. Biomed says it can't be in sterile storage due to the moisture from the cabinet being pulled out through the fans. Infection control says it is okay to put it in sterile storage, and is looking for your clarity or guidance there.
I would have to do a little research on that because it's really going to depend on environmental factors, kind of like what the requirements are for the cabinet and from an electrical standpoint, from a manufacturing standpoint. So I would have to dig into that a little bit. That's a good question. I can certainly do that though and send it to you, Kelsey.
Yeah, that would be great. And if the individual that asked that question wants to put their email address in the chat, I can make sure that I get you that answer directly once Amy has a chance to look at that further.
Okay.
Perfect. Thank you. All right. Other questions, comments, things that folks want Amy's feedback or perspective on? All right, hearing none. Amy, thank you again for a great presentation, very informative. I know there's a lot of chatter in the chat box here with notes of gratitude. So thank you again for your willingness to join. As Julie mentioned at the start, we will have the recording for today's session as well as the slides available, and you will get all of that via email following today's session. So with that, thank you again all for joining and wishing you a great week. Take care.
Thank you.